Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome back to the Deep Dive. Today we are immersing ourselves in, well, the extremely complex yet really critically important world of modern biologics. We're talking about the whole spectrum here. The original reference products, their biosimilars, the interchangeable ones, and even, specialized cell and gene therapies.
Yeah, it's a huge landscape.
These are absolutely innovative, often life-changing medicines, but the operational framework around them, how they're named, tracked, and safely given out in a healthcare system, it's anything but simple.
That's putting it mildly.
So, our mission for you today, the informed listener, is really to help you gain mastery over this crucial regulatory and operational framework and do it pretty quickly.
And that mastery is absolutely essential. The complexity here isn't just some administrative headache. It directly impacts patient safety, regulatory compliance, and frankly, the massive financial efficiency of healthcare organizations.
Right.
If you can't unambiguously identify a product, you simply cannot ensure accurate dispensing, you can't do effective post-market surveillance, or legally make those substitution decisions.
Okay.
So what we've done is synthesize the core guidance into 3 essential pillars. Think of them as supporting the entire system.
That sounds like the kind of structure we need. A solid framework built on distinct pieces.
Precisely. So Pillar 1 is the FDA non-proprietary naming convention. This is the scientific and regulatory identifier. It tells us exactly what the product is.
Got it. The what?
Pillar 2 is the Purple Book. That's the single authoritative source dictating the regulatory relationship between these products. It defines what action is legally permissible.
The rules.
Right. And Pillar 3 is operationalizing safe biologic management. Basically, how you translate that regulatory truth into compliant, state-specific, real-world pharmacy standard operating procedures. The how.
Okay, 3 pillars. Let's start unpacking this formidable structure right where operational safety has to begin with the data itself. Let's dive deep into Pillar 1 and that critical piece of information that makes pharmacovigilance even possible. The name.
Yeah, the naming convention really is the linchpin for everything else.
Yeah.
The structure itself is built around this dual component name. You've got the core name -X.
Core name -X.
Okay, and this isn't arbitrary. It's a very deliberate design choice to make sure the name is not only informative, but crucially, unambiguous. That's absolutely necessary for post-market safety monitoring.
Okay, let's break down those 2 parts then. The core name, that's what most clinicians probably recognize, right?
That's usually the part people know. It's the non-proprietary name, the drug substance identifier that comes from USAN, the United States Adopted Names Council, like adalimumab.
Adalimumab.
The function of that core name is purely about signaling relatedness. The reference product and all its subsequent biosimilars share this core name. It just confirms they contain the same active molecular substance.
So same core name means same basic stuff inside.
Basically, yes. And that's where the suffix becomes, well, regulatory genius, really. The 4-letter suffix is the unique part, like -HJ, XF, or -CNM.
Those random-looking letters.
Exactly. And the FDA specifically mandated that this lowercase suffix be devoid of meaning.
Devoid of meaning. Why?
Well, this seemingly random combination is actually engineered to prevent any perceived endorsement, to make sure no manufacturer can subtly imply through the name that their product is somehow superior or maybe closer to the original.
Ah, so it levels the playing field.
Precisely. It's vital for promoting fair market competition.
So its meaninglessness is actually its most powerful feature in a way. Beyond just the market, what's the specific functional role that suffix plays in pharmacovigilance? Why is it absolutely required for biologics when we don't need suffixes on say, small molecule generics?
That's an excellent question, and it really gets to the heart of the fundamental difference between biologics and small molecules.
Right.
Small molecule generics, like your typical pills, are chemically identical to the original. So substitution and safety tracing are relatively straightforward.
Right, they're exact copies.
But biologics, these are large, incredibly complex molecules. They're often proteins grown in living systems like cell cultures. So while biosimilars are rigorously tested to be highly similar, they are not chemically identical.
Not identical.
And because of that complexity, they carry an inherent, albeit usually small, risk of difference in immunogenicity.
Immunogenicity, the potential to trigger an immune response.
Exactly, the potential to provoke an unwanted immune response in the patient.
Which means if a patient has some unexpected or severe reaction, we can't just blame the core molecule like adalimumab. We have to trace it back to the specific version from a specific maker.
Precisely. That unique suffix ensures that when an adverse event is reported, pharmacovigilance systems can trace it back to the exact product from the specific manufacturer that was actually administered.
Ah.
The FDA's whole post-market surveillance system really relies entirely on this unambiguous identifier to track these events, analyze data trends, and verify product safety over time.
Makes sense.
Without that suffix, if, say, a safety signal emerged for adalimumab, we wouldn't know which specific version was responsible. It would undermine the entire system.
Yeah, you'd have a map.
And it also serves as an immediate red flag, in the pharmacy dispensing environment. It helps minimize inadvertent substitution between products that might be related but haven't yet been designated as interchangeable.
So it's a safety check right at the point of dispensing, too. That makes the suffix crucial. Let's transition now to how those core names get constructed, especially for monoclonal antibodies MABs, because it's always been, well, sophisticated. But the recent overhaul seems to really reflect major scientific advancements.
It really does. Historically, the core name of a MAB wasn't just a random label. It was designed to be a sort of descriptive chemical identity. It was built from 4 distinct parts.
4 parts, okay.
Yeah. You had a random, unique prefix, just a starting syllable to make it unique. Then came the target infix. This was key. It indicated what the antibody targeted, like TU for tumors, Li for the immune system, or foci for cardiovascular targets.
So the name told you what it did, a TU for tumor.
Exactly. And the third element, the source infix, is historically quite interesting. It used to indicate the species the antibody was derived from. You'd see CHU for fully human, ZU for humanized, or MEXI for chimeric antibodies, which were a mix of mouse and human component.
Right, I remember ICSI for chimeric.
That's right. And the whole system always ended with the common stem, FEXMAB, for monoclonal antibody. So take a name like rituximab, you could decode it. Rituximab, it tells you it's a chimeric antibody targeting tumors, too.
That's quite informative.
It was. But over time, especially with advances in genetic engineering, that source infix started to lose its relevance. Species origin became less predictive of immunogenicity compared to specific structural modifications. The system was definitely showing its age by, say, 2017 or so when they phased out using source infixes.
And then came the sheer explosion in MAB development. By the 2020s, that single MAB stem, it became a massive regulatory headache, didn't it? I heard something like over 800 distinct drugs were sharing it.
It was becoming untenable. The sheer density of names ending in HAMAB made it almost impossible to maintain distinctiveness.
Leading to errors.
Exactly. The risk of look-alike, sound-alike LSEs errors just skyrocketed. Imagine a prescriber accidentally clicking on etazolizumab when they meant afaluumab.
Yeah, that's a classic pharmacy safety challenge.
And the old naming system was basically exacerbating it. So the solution wasn't just about adding more unique prefixes. They needed to fundamentally change the stem itself to convey structural detail, which is now considered far more relevant clinically than the original species source.
So, the MAB stem was retired for new drugs, effective around 2021, and replaced with 4 new stems that classify the structure. Let's walk through these, because these are the names our listeners are going to see more and more. Absolutely. These new stems define the antibody's basic architecture, which is really key to understanding its function and potential complexity. Okay, what's the first one? First, we have AIC, TUG, pronounced TUG-DUG. This stands for unmodified immunoglobulin.
Unmodified immunoglobulin, okay.
So, if you see the stem, you know the product is basically a natural full-length antibody. It hasn't been significantly engineered to add novel functions.
Yeah.
It represents the classic antibody structure.
Got it. The standard model, essentially. What's next?
Then there's AIC-BART, B-A-R-T.
Paper price sounds specific.
It signifies an artificial immunobody. This refers to antibodies that are still full-length but have been deliberately engineered or altered. Often this involves modifications to the APC region, the pale end of the antibody.
Why modify the APC region? Oh, various reasons. Maybe to make the drug last longer in the body, so lower half-life, or to enhance its ability to trigger immune responses, or, sometimes, conversely, to silence unwanted immune activity. So, Anibart tells you it's engineered.
Okay, engineered full-length. What about more complex structures? Antibodies binding multiple targets.
Yes, exactly. That's where MIG comes in. MIG. It stands for multi-immunoglobulin.
Multi-immunoglobulin, makes sense.
This stem is reserved for those advanced bi- or multi-specific antibodies. These are engineered to bind 2 or more different targets at the same time. Think of a product like mosunetuzumab, which hits both CD20 and CD3 targets. That falls under CypMIG, signaling high structural complexity and often a very specific clinical use.
Fascinating. And the last one, what about antibodies that aren't even full-length?
Right. For those, we use Ment, M-E-N-T, signifying an antibody fragment.
Fragment.
These products are missing a complete constant region, the FC region we mentioned. This means they might behave very differently in the body, especially regarding how long they last or how they interact with the immune system. So this new system creates 4 highly distinct, structurally informative categories, much safer than the old, overcrowded MAB stem.
That's a huge improvement in clarity.
Oh, definitely. And just a quick note, some of the target infixes were also subtly updated. For instance, the old 2 for tumor was replaced by a slightly different one, to PA. Just ongoing refinement.
That detailed naming structure sounds great for new drugs. But it immediately brings up what you called the naming asymmetry challenge. If that 4-letter suffix is so critical for safety and tracking, why did the FDA decide not to go back and add suffixes to all those older, well-established reference products? What was the thinking behind that 2019 policy decision?
That's a really important practical point. The official rationale from the FDA was primarily about avoiding massive confusion and potential errors in the already established market.
Yeah.
They were concerned about the risks associated with suddenly forcing name changes on products that had been safely used, sometimes for decades, under their original unsuffixed names. Think about drugs like filgrastim or insulin glargine.
Right, clinicians know those names inside out.
Exactly. The FDA prioritized stability and continuity for those existing reference products. They reasoned that slapping a new suffix onto, say, filgrastim could actually increase the risk of dispensing errors or clinician confusion, at least initially.
But the immediate side effect, intended or not, is this subtle, non-clinical barrier to adopting biosimilars. Right? You have the older reference product, let's stick with filgrastim, with no suffix, while all its new, equally effective competitors get suffixes like filgrastim centers.
That's precisely the challenge. This naming disparity subtly frames the unsuffixed product as the original, maybe the gold standard, in the minds of some prescribers, pharmacists, and even patients.
Even though scientifically.
Even though the FDA's scientific determination is that the biosimilars are highly similar with no clinically meaningful differences, but that lack of a suffix on the originator creates, well, an operational hurdle and sometimes a psychological preference for the unsuffixed product. It's definitely a headwind for biosimilar adoption.
If we look at that asymmetry through the lens of Pillar 3, the operational side, how does that unsuffixed original complicate things in the pharmacy information system, the PIS?
Oh, it definitely complicates the IT build. Pharmacy informatics teams basically have to create manual exceptions or specific mappings in the system.
Because the system expects core named XX.
Right. The system is designed to track products using that full core name XX structure. When an order comes through for just plain filgrastim, the system needs a special flag or rule. It has to know that this single name represents the reference product within the broader filgrastim family, and that the other products with suffixes are its competitors.
So more manual work.
Yes, it adds steps, increases the need for manual maintenance of the drug database, and frankly, introduces more potential points for human error during system configuration and updates.
Okay, now let's apply this whole naming principle to the real cutting edge. Cell and gene therapy, or CGT.
Right. With CGT, the stakes are arguably the highest, and the naming conventions reflect that complexity. The core names themselves are often incredibly long and technical. They use specific stems like E-gene for gene therapies, think Parvovex Shoy.
Wow, that's a mouthful.
It is. Or you have G-cell for cell therapies like Axicabtagene Silolicel. These names are long, complex, and honestly visually confusing sometimes.
And a mix-up here could be devastating.
absolutely catastrophic. Many CGT products are personalized, sometimes manufactured for a single specific patient. A product mix-up isn't just inconvenient. It could be fatal or render the therapy completely ineffective.
So in that context, the short, distinct four-letter suffix becomes an indispensable safety tool precisely because the core name is so complex and prone to transcription errors.
It functions almost like a mandatory confirmation code. The long core name tells you the type of therapy, but that short suffix, like nextoi or whatever it is, provides the unambiguous proof of origin and identity for that specific batch or product line.
Like a final check.
Exactly. And since CGT products are often tracked using really rigorous chain of custody protocols from manufacturing all the way to the patient, that distinct suffix becomes a critical data point for ensuring supply chain integrity. It's much less susceptible to human error during data entry, verification, scanning, than trying to perfectly type or read that incredibly long core name every single time. Okay, so once we've successfully identified the product using that rigorous naming convention, the next big operational hurdle is understanding the rules around that product. What are we legally allowed to do with it?
Right.
And that brings us squarely to Pillar 2, the Purple Book. Remember, the naming convention tells you products are related, maybe highly similar, but you need the Purple Book to know the official rules governing that relationship.
So it's the official referee.
That's a good way to put it. It's the FDA's database of licensed biological products, and it serves as the single authoritative resource for this information.
It's basically the source of regulatory truth for all biologics, isn't it? I heard it evolved from just being static PDF lists because the market just grew too complex and fast for those to keep up.
That's exactly right. The pace of approvals, especially for biosimilars, made static lists obsolete almost immediately. The current Purple Book is a fully searchable, dynamic online database. It's comprehensive across the FDA's regulatory centers, too.
What do you mean, across centers?
It includes all biologics licensed by both CDER, that's the Center for Drug Evaluation and Research, and CBER, the Center for Biologics Evaluation and Research.
Okay. Why is it important to have both CDER and CBER products together in one place?
Well, biologics get regulated by one or the other based on their category and mechanism. For instance, most monoclonal antibodies fall under CDR, while things like vaccines, cell therapies, blood products, those are typically under CBER.
Got it.
By aggregating everything, the Purple Book gives users one single place to look up the definitive regulatory status of any licensed biologic, doesn't matter which center approved it. And its primary purpose, its core function, is to codify those legal and scientific determinations from the FDA.
Codify the status.
Meaning it explicitly states whether a product holds a reference product license, that's Pathway 351A, a biosimilar license at Pathway 351K, or, most critically for substitution, an interchangeable biosimilar designation, also 351K, but with added requirements met.
Okay, let's revisit that pharmacist scenario we touched on earlier. They have two related products with different suffixes. Intralumababnon versus intralumabaj JTNR. How does the Purple Book provide the final piece of the puzzle for that pharmacist?
Right, so the pharmacist takes several steps. First, the shared core name, intralumabab, suggests they contain the same active substance. That's step one.
Okay, they're related.
Second, the different suffixes, arginine versus JTNR, immediately confirms they are separate, distinct licensed products. This prevents any reckless or automatic substitution. It's the safety trigger.
Stop and check.
Exactly. Then comes the final crucial step, the Purple Book query. The pharmacist searches for intralumab JTNR in the database. Within seconds, the Purple Book provides the definitive regulatory answer. It will clearly state, is intralumab JTNR designated by the FDA as interchangeable to the reference product, which in this case might be intralumababnon.
And that answer dictates the next action.
Absolutely. If the Purple Book says yes, interchangeable, then pharmacy-level substitution is scientifically sound, though. Importantly, it's still subject to state law, which we'll get to. If the Purple Book says no, or just lists it as biosimilar, then it's related, it's effective, but it is not eligible for automatic pharmacy substitution without prescriber intervention. Hashtag 2.2 key data fields for operational intelligence.
Okay, that makes sense. Now, for our listeners who are really in the weeds with inventory management, formulary decisions, pharmacy informatics, the data experts with specific data fields within the Purple Book are absolutely non-negotiable. What do they need to pull into their systems for operational intelligence and to drive that dispensing logic?
Yeah, for that level of operational detail, we really need to focus on two absolutely critical data points: the BLA number and the license type.
BLA number and license type.
Okay. The BLA number, that's the Biologics License Application Number. Think of it as the definitive, unique regulatory fingerprint assigned by the FDA when the product is first licensed.
A fingerprint, unique and permanent.
Exactly. It's essential for precise ordering, receiving, and reconciliation processes. It's often confused with the National Drug Code, the NDC, but they serve completely different purposes, and that confusion can be dangerous.
Can you clarify that difference? Why is it so important for systems to track both the BLA and the NDC, and what can go wrong if they rely only on the NDC?
Great question. The NDC is primarily a commercial identifier used for billing and packaging. Critically, it's temporary and changeable. An NDC changes with different strengths, dosage forms, package sizes. It even changes sometimes if the product ownership changes hands between companies.
Ah, so it's not stable.
Not reliably stable for identifying the core licensed product itself. The BLA, however, is permanent for that specific licensed biologic. It links that product with its unique suffix back to the original application, the manufacturing process, all the data approved by the FDA.
Okay.
So relying solely on the NDC for identification in ordering or receiving is risky because NDCs can change or be reused in ways that might obscure the actual BLA product identity. Best practice demands using the BLA number, usually combined with the full proper name, core name plus suffix, as the definitive secondary identifier on purchase orders, and it absolutely must be verified upon receipt.
To ensure you got the right licensed product, not just a similar package.
Precisely. You ensure you have the correct BLA-approved entity, not just something that looks similar or comes in the right size box.
Okay, so BLA is the regulatory fingerprint. What about the license type field? You said that's the legal gatekeeper.
It absolutely is. This field is everything for substitution compliance and formulary management. It explicitly confirms the regulatory pathway used for approval. 351A for the original reference product, or 351K for a biosimilar or an interchangeable biosimilar.
And that interchangeable tag is key.
It's the magic word for potential pharmacy-level substitution. And for formulary managers looking ahead, another critical piece of data often found in relation to the reference product is its reference product exclusivity expiration date.
The 12-year exclusivity.
That's the one. 12 years from the initial licensure date of the reference product. Knowing this date is crucial for strategic planning. It tells the institution when new biosimilars are legally permitted to enter the market, which dictates future inventory shifts, contract negotiations, and budget forecasts, often years in advance.
From a purely practical standpoint, how do administrators or the informatics teams actually use the Purple Book interface effectively? How do they get this crucial information out and integrate it into their hospital or pharmacy systems?
The FDA actually designed the online Purple Book pretty well for different user needs. They provide two main search modes. There's the simple search.
Simple search for quick checks.
Yeah, exactly. It's designed for those daily, quick clinical queries, like that pharmacist scenario we discussed. It's highly visual, uses these color-coded product cards that clearly link all the members of a product family. You see the reference product right next to its listed biosimilars and any interchangeables. It's perfect for answering, is this related, and what's its official status? Quickly.
Okay, simple for quick lookups. What about the advanced search? That sounds like it's for the data crunchers.
That's exactly who it's for. The advanced search is paramount for pharmacy informatics specialists, formulary administrators, anyone needing bulk data or specific filtered views.
What can you do with advanced search?
It allows filtering by multiple criteria at the same time. You can filter by license type, show me all interchangeables, by specific dosage form, by BLA holder, or even by BLA approval status. But critically, the most important feature of advanced search for system integration is the ability to export the data.
Export it now.
You can export structured, machine-readable data, typically as a CSV file or an Excel spreadsheet. This is absolutely non-negotiable for integrating the FDA's data into institutional systems.
Right, because you can't manually type all that in. This really raises a core informatics question. How do pharmacy teams take this relatively static exported data from the Purple Book and effectively embed it into the dynamic real-time workflow of their pharmacy information system, PIS, and their electronic health records, EHR, to actually automate safety checks and manage substitution rules?
This is really where we connect the dots between Pillar 2, the data, and Pillar 3, the operation. That exportable Purple Book data is gold. It's used to build and maintain the institution's internal drug master file or formulary database.
Okay, so the data gets mapped internally.
Precisely. For instance, the BLA number from the Purple Book export gets mapped directly to the specific product record in the PICE. And crucially, That license type field, especially the interchangeable designation, is translated into a specific flag or attribute within the PI-SACHER drug record.
A flag that drives logic.
Yes. That flag becomes the control switch for automated substitution logic. When a prescription or order is processed, if the pharmacy system considers substituting the prescribed product, for example, the reference, with another, maybe an interchangeable, it references this internal flag derived from the Purple Book data.
And if the flag says interchangeable,
Then the system knows substitution is potentially permissible, again, state law permitting. If the flag is biosimilar or absent, substitution is blocked. Furthermore, in sophisticated environments using high-level communication standards like HL7 messaging for orders, dispensing, and administration records, specific data fields are configured to ensure the full proper name, core name plus suffix, and the BLA number are transmitted, not just the potentially ambiguous core name or a temporary NDC.
wow. So without that structured data integration from the Purple Book export, those crucial substitution checks would basically remain manual processes.
Exactly. It would render the entire system fragile and highly dependent on individual pharmacist vigilance for every single transaction, which isn't sustainable or optimally safe as volumes increase.
Okay, so we have the knowledge, the correct name, Pillar 1, and the official regulatory status from the Purple Book, Pillar 2. But that knowledge is only valuable if it's actually translated into rigorous, standardized, real-world procedures. And that's the whole point of Pillar 3, right? Operationalizing safety.
That's it, exactly.
The safety risk, especially with more and more biosimilars hitting the market, is that institutions might get complacent, maybe relying just on brand names, or incomplete non-proprietary names, which you've made clear is insufficient and, frankly, unsafe.
That's the operational mandate we absolutely have to instill. The primary identifier used in all electronic systems, the EHR for ordering, the PIS for verification and dispensing, the automated dispensing cabinets, ADCs, for storage and retrieval, it must be the full proper name, including the suffix.
No exceptions.
No exceptions. Allowing a clinician to order or pharmacy staff to stock simply based on adalimumab without specifying the suffix is just setting the stage for a potentially catastrophic error, especially if the institution has multiple different suffixed versions of adalimumab on its formulary.
And you mentioned the BLA number earlier as providing that crucial supply chain integrity check.
Correct. We must implement what amounts to a closed-loop system for identification. The BLA number acts as that definitive secondary identifier. It needs to be used on purchase orders, and then it must be verified, ideally via barcode scanning during the receiving process.
Connecting ordering to receiving.
Yes. By systematically ensuring that the proper name with suffix and the license type pulled from the Purple Book data are accurately mapped within the system and tracked via the BLA number throughout the workflow, we create that closed loop. It ensures the right product is ordered, the right product is received, the right product is stocked, and the right product is dispensed, all in full compliance with both the federal designation and the specific state dispensing laws.
Let's get really practical now and detail the essential components of a model standard operating procedure, an SOP. This is where the operational rubber really meets the road for the pharmacy staff, the technicians, the pharmacists on the ground.
Okay, a robust SOP has to cover the entire medication use process. It starts right at ordering.
Within the EHR.
Yes. Institutions must configure their EHRs to prohibit core name-only orders for these biologics. The system should force the prescriber to select the specific product, which is linked internally to its unique BLA number and its full proper name with the suffix.
What about that issue of the unsuffixed reference product, sometimes being the default?
That default bias needs to be actively managed through informatics configuration and prescriber education. The system shouldn't make it easier to pick the original just because it lacks a suffix.
Okay, so ordering is tightened up. Next stop, the receiving dock. That seems like the first physical line of defense against mix-ups.
It absolutely is.
Okay.
So for receiving, the SOP must mandate that staff rigorously verify not just the NDC, but also the BLA number and the full proper name on the received product against the original purchase order detail.
Manual checking.
Manual checking is the minimum, but best practice strongly recommends, almost mandates, the use of barcode scanning verification at receiving.
By barcode specifically.
Because scanning the barcode on the product package, which typically links to the NDC and the PIS, ensures that the physical item received matches the electronic record associated with the purchase order, which should be tied back to the intended BLA number. It closes that loop electronically and reduces transcription or visual check errors. Next comes storing. This is equally critical, especially when you have multiple products with the same core name.
Like several adalimumabs.
Exactly. Products that share a core name but have different suffixes must be physically segregated in the main pharmacy warehouse or storage areas. Don't store filgrastim sendis right next to filgrastim affi.
Makes sense. What about in automated dispensing cabinets on the nursing units?
Same principle applies electronically. They need to be in separate, clearly labeled pockets or drawers within the ADC. Clear visual labels on the storage locations and distinct electronic identifiers in the ADC software are absolutely essential to prevent someone grabbing the wrong vial or syringe under pressure.
Okay, segregated storage. And finally, the last point of contact before it reaches the patient, dispensing.
The dispensing phase relies entirely on that integrated PIS logic we talked about. The SOP must require barcode scan verification of the specific vial, syringe, or package being dispensed against the patient's order in the PIS.
Scan the item before it goes out.
Every single time. And crucially, if a substitution is made, meaning an interchangeable biosimilar is being provided instead of the reference product that was originally prescribed, the PIS must perform that check. It must confirm that substitution is actually permissible based on that interchangeable flag derived from the Purple Book data.
And if it's not flagged as interchangeable?
Then the system absolutely must issue a hard stop or, at minimum, a very severe alert that requires pharmacist override and documentation. It cannot allow a non-interchangeable biosimilar to be substituted automatically at the pharmacy level. The system enforces the rules. Now, if we connect this operational compliance piece to the bigger regulatory picture, we have to address a kind of regulatory paradox. It's this split between federal and state authority. Well, the FDA, at the federal level, provides the scientific designation. They're the ones who say, yes, this product has met the rigorous standards to be called interchangeable. They confirm it's scientifically sound for substitution.
Okay, FDA says it's safe to swap.
Right, but then the actual practice of pharmacy-level substitution, whether a pharmacist can or must make that swap without calling the doctor, that's governed entirely by state law.
So the federal government gives the scientific green light, but the state government dictates the traffic rules for actually making the turn.
That's a perfect analogy. The distinction between federal scientific authority and state legal authority over the practice of pharmacy is the major operational challenge here.
Which means that a biologic product that the FDA has designated as interchangeable, having proven its clinical equivalence through those demanding switching studies, might still be illegal for a pharmacist to substitute automatically in one state, while maybe even being required for substitution in another state.
Exactly that. Achieving that interchangeable status from the FDA is an extremely high scientific bar. It requires those complex switching studies demonstrating no increased risks or reduced efficacy when patients are switched back and forth multiple times between the reference product and the interchangeable. That's the tough FDA part. But once that status is granted, healthcare systems and pharmacies must navigate this incredibly varied and dynamic compliance framework dictated by 50 different sets of state laws and regulations.
Okay, what are the main kinds of variations we typically see across these state substitution laws? How do they generally differ in what they allow or require for pharmacy-level substitution?
Broadly speaking, you see state laws falling into a couple of major categories regarding interchangeable substitution. Many states are permissive substitution states.
Permissive meaning?
Meaning the law allows a pharmacist to substitute an FDA-approved interchangeable product for the prescribed reference product, unless the prescriber has specifically indicated that the brand name is medically necessary. The pharmacist has the option, but isn't forced to substitute.
Okay, they can substitute.
Then you have a smaller number of mandatory substitution states.
Mandatory sounds stricter.
It is. In these states, the law generally requires the pharmacist to dispense the less expensive, therapeutically equivalent interchangeable biosimilar unless the prescriber explicitly mandates the brand name using specific language, or sometimes if other conditions aren't met, like maybe patient cost-sharing rules.
So the default action changes.
Fundamentally, in permissive states, the default might be the brand unless substitution occurs. In mandatory states, the default is often the substitution unless explicitly blocked.
Let's use the specific requirements of Texas law as a really concrete example to illustrate just how detailed and complex this state-level compliance can get for a pharmacy system.
Texas is a great example because its law has several distinct and very specific requirements that systems and pharmacists must manage. First, look at the conditions for substitution. It's not automatic, even if the product is interchangeable.
What are the conditions in Texas?
The interchangeable product must demonstrably cost the patient less than the prescribed reference product. That cost saving has to be real. And importantly, the pharmacist must inform the patient or their agent that a less expensive interchangeable option is available, explain what that means, and get the patient's consent before making the substitution.
Patient consent is required. Interesting. What about blocking the substitution? How specific does the prescriber need to be in Texas?
Astonishingly specific. To prohibit substitution in Texas, the prescriber must actually handwrite the phrase brand necessary or brand medically necessary directly onto the face of a written prescription.
Handwrite it. What about electronic prescriptions or checking a box?
The law explicitly invalidates pre-printed checkboxes, stamped instructions, or even just standard electronic flags that might say, dispense as written. For biologics, Texas requires that specific handwritten phrase on paper scripts to block substitution. The intent seems to be to force a very deliberate, non-default decision by the prescriber if they truly believe the brand is needed over an interchangeable. How this translates perfectly to e-prescribing workflows is still an area of evolution.
Wow, that's incredibly specific. Okay, so let's say the conditions are met, consent is given, substitution happens. Is the pharmacist's legal duty done then?
Not quite in Texas. There's a critical communication after a substitution requirement.
What do they need to communicate?
The pharmacist must notify the original prescribing practitioner about the specific substitution that was made. This notification has to include the name of the product actually dispensed and its manufacturer, or more practically, its National Drug Code, NDC.
And there's a time limit.
Yes. Notification must be made no later than the 3rd business day after the interchangeable product was dispensed.
3rd business day. How is that notification supposed to happen? A phone call? Fax?
The law encourages, and for large health systems practically requires, using an interoperable electronic system. This could be a notification message within the shared EHR, a secure email, or some other electronic interface. The goal is timely, documented communication to ensure the prescriber's record is updated for pharmacovigilance continuity.
Makes sense. Anything else in Texas law?
Yes, one more piece, labeling. The label on the actual dispensing container, the bottle or box given to the patient, must clearly indicate that a substitution was made. Typically using a phrase like substituted for brand name prescribed or similar wording required by the Texas State Board of Pharmacy.
So multiple checks, specific prescriber action, patient consent, communication back, and clear labeling. That really highlights why Pillar 3 requires such intensive system configuration and staff training just to handle one state's rule.
Exactly, and multiply that complexity by 50 states, each with its own nuances. It's a massive operational undertaking.
We've covered the technical naming, the regulatory lookups, the complex state laws, the SOPs, but underpinning all of this, especially when a substitution does occur, is patient trust. Patients receiving these complex, often expensive therapies need clear reassurance. What stands out to you as the most critical element for maintaining that trust and ensuring adherence during this process?
You've hit on arguably the most important factor for success. Clear, consistent, and confident communication from the pharmacist or counselor. When a switch is planned or made to an interchangeable biosimilar, we have to proactively address the potential anxiety the patient might feel. Ignoring it is not an option.
So what are the key points that absolutely must be covered in that counseling session?
I think there are 5 essential points that need to be addressed clearly and concisely every single time.
5 points. Okay, what's number 1?
First and foremost is reassurance of equivalent safety and efficacy. The pharmacist needs to state unequivocally, the FDA has determined this product is scientifically interchangeable. That means it works exactly the same way as the medicine you were taking before and is just as safe. Using that FDA designation gives it authority.
Okay, establish equivalence right away. What's second?
Second is confirming consistent administration. Reassure the patient. You'll take this medicine the same way, same dose, same timing, same injection method, same device if applicable. Any perceived difference in how they use it will immediately erode trust and raise questions.
Keep everything the same from the patient's perspective. Third point.
Third is managing expectations about side effects. Specifically confirming the expectation of the same potential side effects. The message should be, you shouldn't expect any new or different side effects just because of this switch. The potential side effects are the same as your previous medication. If you do notice anything unusual, please let us or your doctor know.
So, no surprises expected there. What's number 4?
Fourth, we need to clearly highlight the primary reason for the switch, which is usually cost. So, highlighting the potential for cost savings is key. Frame it positively. This switch allows us, or your insurance, or you, to potentially save significant costs without compromising the quality or effectiveness of your treatment. Connecting it to value is important.
Right, the why. And the fifth and final point.
Fifth is ensuring the patient feels supported after they leave. This means providing additional vetted resources. This could be pointing them to official FDA patient education materials online about biosimilars, or providing a simple handout, and clearly defining the next steps. Here's who to call if you have questions about insurance coverage, or call your doctor or our pharmacy if you think you're experiencing a side effect. Empowering them with resources and contacts is crucial.
Equivalent safety, consistent use, same side effects, potential savings, and resources. That sounds like a solid checklist.
It really is. Addressing those 5 points proactively, confidently, and empathetically can turn a moment of potential patient confusion or anxiety into a reinforced moment of clinical partnership and trust. That's vital for long-term adherence with these critical therapies.
We've definitely completed a comprehensive deep dive today into this intricate framework. Let's just quickly synthesize those 3 pillars again. We started with the sophisticated dual-component naming convention, Pillar 1 for unambiguous identification, then Pillar 2, the Purple Book, providing the regulatory truth via the BLA number and the crucial license type. And finally, Pillar 3, the rigorous, detailed SOPs needed to translate that federal guidance into state law compliant, safe dispensing practices in the real world. It really feels like mastering this integrated framework is, as you said, the power to optimize both healthcare efficiency and, most importantly, patient safety.
And having this framework is absolutely essential because this landscape is just evolving at, well, breakneck pace. The biosimilar pipeline is rapidly expanding, moving into really lucrative and clinically critical areas like immunology and oncology. This promises greater patient access and much-needed market competition.
We're just seeing more approvals all the time.
All the time. And concurrently, we're also seeing the FDA continue to refine its regulatory science. There's ongoing discussion, for example, about potentially streamlining the data requirements needed to achieve an interchangeable designation in the future, which reflects the agency's growing experience and confidence in the rigorous processes already established for biosimilarity.
So things might get even more dynamic.
Absolutely. Which means continuous education for everyone involved, pharmacists, techs, prescribers, informatics teams, and the diligent application of these 3 pillars we discussed that remains paramount for the safe delivery of these advanced medicines.
So what does this all mean for you, the listener? Hopefully, you now feel equipped with the technical, the regulatory, and the operational intelligence needed to be an expert gatekeeper in this space. To understand not just what the rules are, but why they exist and how they fit together. Now, we talked quite a bit earlier about that powerful, though non-clinical perception created by the naming asymmetry, the fact that older reference products often lack the suffix, which can subtly make them feel like the standard or the original, even though that suffix difference is scientifically meaningless in terms of quality.
That inherent bias.
Right. So, as the market continues its steady shift, with more and more interchangeable biosimilars coming online, all of which will carry suffixes under the current policy. And as the pressure from massive potential cost savings becomes an even greater influence on formulary decisions. Here's a final provocative thought for you to mull over as you encounter these products and systems in practice. Will that inherent bias favoring the non-suffixed original product eventually just be eradicated? Will overwhelming clinical reassurance, provider experience, and sheer market economics render that initial naming asymmetry moot? Or is that initial non-clinical advantage of being the originator name too deeply embedded in prescribing habits and maybe even patient perception to disappear entirely, even when faced with interchangeable alternatives?
That is really the operational and market dynamic challenge that will likely define pharmacy practice and formulary management for the next decade. Something to watch closely.
Indeed. Thank you so much for joining us for this deep dive into the complex world of biologics naming, regulation, and safe management. We'll see you next time.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.